Okay, so thanks everybody for joining in. Artie had a conflict today, so I'm stepping in for her. I will be moderating today. And if you have cases, just send them notes through the chat. Otherwise, I think, Roopa, you said you have a case from the start?
Yeah, sure. Mine will be a quick one. Let me share screen. Victoria, you have to enable my screen sharing. It says host has disabled screen share.
Should be able to do now.
Okay. So quick case, 60-year-old with 3-month history of dysphagia. It's an obvious finding, but just to go over a few differentials and terminology. Anybody wants to say anything or write anything?
So Steve writes lipomatous mass.
Right.
Um,
Anybody wants to add on anything? Yes, there is a large amount of macroscopic fat in it. And
so is that
no,
it's not that stuff. You know that fiber something stock?
right,
Out, is that it?
you're right. So that's what I was going to bring your attention to, this area, which is a little broad based. It has it's attached to the wall over here. And if you look at the location, this is just below the cricopharyngeus muscle. It's in the upper esophagus. And then lower below, it sort of just balloons out into more of this sausage-shaped mass. Like Steve said, the density is predominantly fatty, but we do see areas of soft tissue interspersed within this fatty mass. And the characteristic term they use is a sausage-shaped mass with a bulbous tip and pedicle or a stalk, usually in the cervical esophagus. So different terminologies have been used to describe this. People have called this fibromas, lipomas, hamartomas, but the WHO, I think in 1996, went ahead and put them all under this umbrella term of fibrovascular polyp. And in this case, this happened to be an incidental thyroid mass as well. So patient got treated for that. So few things to know about this entity are, it's scary because they have reported sudden death from people regurgitating this out into the pharynx. So in AIRP best cases, they have a few very gross cases of these regurgitating and resulting in sudden death. Otherwise, mostly it's just dysphagia. And it just arises from the submucosa of the cervical esophagus and just gets pushed down because of constant esophageal peristalsis. It's covered by squamous epithelium. If it's very small, it may not be seen endoscopically. And as radiologists, we need to try and look for that pedicle. It can have a variable amount of fat, and most of the times it gets surgically excised. This is another case report I found in the literature where it had a similar broad-based stalk of attachment, again high up just below the cricopharyngeus muscle. But if you look at the density in this one was predominantly soft tissue with just a small amount of fat in it. And again, 7 centimeter or so is the average size. Found this rather gross picture on radiographics from one of the AIRP cases where a patient was actually regurgitating this. And at surgery, this is what these look like, very sausage-like. And just to review other benign submucosal tumors of the esophagus, leiomyomas, of course, are the most common ones. They come from the smooth muscle layer. And GISTs are less common. They're only 5% of the mesenchymal tumors in the esophagus. And EUS, they say now, has a big role in trying to differentiate. It used to just be histologic. If it was from smooth muscle, we would call it leiomyoma. If it was from the pacemaker cells of Cajal, we would call it a GIST. But now on imaging also via EUS, we can try and differentiate these preoperatively. And then other rare benign tumors, granular cell ones, these tend to be homogeneous smooth masses, hard to differentiate from leiomyoma, but pathologically it's quite a distinct entity. And This was just a companion case of an esophageal cyst. This one happened to be high up in the esophagus. Most of these are in the lower third, closer to the cardia. But this one was a companion case to the first case I showed, where the density is entirely different. And you can see the submucosal nature because it's pushed out the mucosa and the air-filled upper esophagus is pushed out to one side. And this one had an MR incidentally. And we see the heterogeneity due to necrosis, which is much more commonly described with esophageal cysts than with esophageal leiomyomas, which tend to be more homogeneous, have that whorled low T2 appearance. So based on some imaging features, we can help tell what a benign mass is. But I thought this entity was interesting just because it can predispose someone to sudden death, not knowing they have like a 10 centimeter esophageal mass. So just a quick case.
Very cool case. Thank you, Roopa.
Yeah.
Okay. Does anybody else have cases to share? Okay, then I'll, in 1 second, I'll start sharing some of my packs. This side's down, please. Okay. I have several cases in a good pickup, bad miss category, and then an interesting case. So this was a patient who came into the emergency room with right lower quadrant abdominal pain for a few days. And any thoughts? Bring up the chat so I can see. I don't think, I'm not sure I can see the chat and the, oh no, I can. Sorry. So I'm having a hard time seeing the chat along with the presentation. So if you have a thought, can you please just unmute yourself and speak up?
Fecalith in the right lower quadrant? Like an appendicalith maybe?
Right, so, with this, obviously with the right lower quadrant history, we're kind of focusing on the appendix. Yes, you're right, there's a little appendicalith, but what do you think of this thing?
A fishbone or something poking out?
Right, so you can see that, first, when we look at it, it kind of looks like an artifact, and if you come here, there was another artifact here, so it was kind of almost dismissed it as an artifact. And then on the sagittal, well, even on the axial, you sort of kind of see this, right? So then maybe it's not an artifact. There's a little schmutz around it.
Looks metallic.
Right. This is exactly what I thought. So like the resident was like, oh, this is probably a fishbone. And I thought this was going to
be... Wire bristle can do that if you are kind of eating food, which is like a grilled food.
Barbecue.
So I also thought that this was a little too dense for fishbone, but the patient did have a.
Nanda said wire from a grill brush.
Oh wow!
Yeah, that's what I thought too.
So one of the things that I found very useful in confirming that it's not a fake out. If you look at the source images on the 0.6 to 5 millimeter images, you can see for sure that it's not a fake out, it's not an artifact, it's an actual thing. So I also said, I think this is not a fishbone because it's just too dense. But the patient's history was that he ate a fish soup, right before his pain started. So, and the patient was taken to the OR and it was a fishbone, but one of the things that came out in the OR, which I still don't know how to reconcile, is that this thing was perforating Meckel's diverticulum. And when I came back, I went back and I looked, and I still can't see where which part of it is an actual diverticulum. So if you guys can figure it out, that'd be great. Otherwise, I'm going to assume that it's somehow folded upon itself and we can't really see it. But I couldn't, even knowing that that's what they saw in surgery, I went back and looked and I could not see where the diverticulum is.
It's tough to follow.
Huh?
It's tough to see the knuckles, I guess.
Right. So I just couldn't figure, like, I couldn't even see something that potentially, I don't know, it's probably folded on itself, and presented with pain and persistent bleeding after C-section. And this is the ultrasound. And, you know, she's, you know, through the, you know, it's a difficult sono to make, you know, because there's the bandages, you know, but you can see that there's a mass-like structure in the, in like lower uterine segment with a lot of vascularity. And the patient went for MR. And this is what we see on MR. Sagittal T2, you can see, this is, you know, the where the C-section scar should be. And you can see the scar is expanded by this process. And here's T1.
I worry if I'm looking at some flow voids.
Right. Right. So, you know, we see T1 intermediate, T2 bright. So that's, you know, good for like subacute blood. There are also T1 hyperintense, T2 hyperintense areas, you know, which are good for late, you know, early subacute blood. And then when we give contrast, this is a very old case, so that's why we don't have a fat set here, but you can see that a bunch of areas here actually enhance. So any thoughts of what this could be?
Complex hematoma, pseudoaneurysm.
I'm sorry?
Hematoma or pseudoaneurysm.
Okay, so one thought we thought it was pseudoaneurysm, but I'm actually withholding one piece of information, clinical information from you guys.
Did she have any known vascular malformation before?
No, but what she did have is the abnormal placentation, and during the C-section, they weren't able to extract the placenta. So this, you know, so this whole thing is a basically remnant of placenta, and this was per creta, and the patient actually ended up having a hysterectomy, and there was invasion of the bladder, which I don't necessarily, you know, again, older case, it's hard to see on the MR if it was, you know, actually seeing it, but this was the case, and again, this is like from many years ago. So I think at this point, you know, now they would probably try to embolize it and see if they can shrink the placenta to try to preserve the uterus. But in this case, they ended up doing hysterectomy. So this is a per creta retained after C-section.
That's amazing.
So,
Victoria, I do have one case when you're finished.
Do you want to, well, I think we have time. Unless you want to go and then I'll come back.
No, go ahead.
Okay. So this was an interesting case. It's a patient with cirrhosis, and this one is 2 years ago. And you can see that 2 years ago, the patient had this lesion. It was measured about 1.2 centimeter. So it was hypointense in hepatobiliary phase, and then it was seen as like so on hepatic arterial phase. So you can see that there was a load of hyperenhancement, and there's really no washout appearance. So at this point, a person who read this study described it as having arterial phase hyperenhancement, no washout appearance, no capsule appearance, 1.2 centimeter. And they assigned LIRADS category 2, favoring a what do you call it? A shunt. So does anybody have any thoughts about that interpretation? This is an EVIS study, so you can see hepatobiliary phase. And the area that had arterial phase hyperenhancement also has hypointensity on the hepatobiliary phase. So in this case, whenever we see something that's discrete like this and has hypointensity on hepatobiliary phase images, it's at least a 3, right? So the chance, especially when it's this hypointense. So at this point, the choices would have been between 3 and 4. It's a 1.2 centimeter lesion with arterial phase hyperenhancement, no other major features that would lend you into 3 cell, and you can bump it up if you wanted to based on hepatobiliary phase to make it a 4. So between 3 and 4, those 2 categories would be appropriate, but based on hepatobiliary phase, this is LR2 is really not a correct category.
Sorry, can you show the venous phase?
There's really no washout appearance, no capsule appearance.
Yeah, I mean, it looks so rounded. Like, I don't know that I would have called it perfusional.
Right. So, I mean, rounded appearance, should raise kind of concern, but certainly some rounded, there are plenty of cirrhotics with rounded appearing perfusional variants. Although, again, whenever you see something rounded, I guess it should raise at least a bell to be cautious. But really, what's important here is hepatobiliary phase hyperintensity, because that confirms that there's a true something there. And in cirrhotic patients, nodules which are hypointense on hepatobiliary phase are usually somewhere between dysplastic nodules, HCCs, early HCCs, things like that. Well, anyway, so this patient came back in May, and so remember, this was 1.2 centimeter called LIRADS 2. So now patient comes back, and in May of this year, sorry. So now you can sort of begin to see it on pre-contrast as slightly hypointense. Sorry, PAX is a little slow here, but you can see a much more prominent enhancement, right? Although, you can argue that this phase is, this acquisition is slightly later than this phase, so that could be that. And now, here's the portal venous phase. Okay, so now you begin to see what looks like a washout appearance. And then we'll go back and look at the hepatobiliary phase images. Again, we see, if we scroll fast enough, we will see that it was hypointense on hepatobiliary phase images. Okay, and at this point, this was measured 1.5 centimeters, and it was interpreted as having arterial phase hyperenhancement, as having no washout appearance, and then so based on these findings, they assigned the category LIRADS 3. They also thought that there was size stability for over 2 years, which is an ancillary feature of benignity, even though this was 1.2 centimeters was 1.5 centimeters. So two things happened here. The washout appearance was kind of not detected, and the subtle change in size was dismissed as perhaps measurement error. So the category was assigned was 3. So this was in May, so now it's August. So once you go to LIRADS 3, the appropriate follow-up is every 3 months. So now you can see the patient, clearly has pretty avid enhancement of this lesion. When we go to portal venous phase, it's much more obvious that we have the washout appearance. Maybe a capsule appearance, that's arguable, but maybe. And if you look at the hepatobiliary phase images, you can see in these 3 months, the size went from 1.5 centimeter to about 2 centimeters. So you can see that, so now this is clearly LIRADS 5, HCC, no differential diagnosis. So you can see how, the HCCs can have this interesting pattern where they kind of grow, either stay stable for a while or grow a little bit, and then at some point they just kind of pass this threshold and begin to explode. So again, teaching point here, be careful anytime you see something that's rounded and arterial phase hyperenhancement, very, very careful about looking for washout appearance. And then be very concerned, very, very cautious about lesions which are hypo-intense on hepatobiliary phase images. They should be scrutinized, and usually they're going to be at least LIRADS 3 or higher. Any questions or comments? Okay. All right, so why don't I stop sharing, and then I can resume if we have time. Okay, who's going next? Okay, Nelly. Nelly, I think we can't hear you.
Can you hear me? Okay, good.
Yeah, now.
All right, so we have a patient with cirrhosis, and they got an MR. We applied LIRADS, of course. This little lesion is like sub-centimeter, and it enhances washout, but it's under 1 centimeter, so it's an LR4. So per Victoria's awesome lecture, that LIRADS series, lesions that are, LR5 have to be at least 1 centimeter with arterial phase enhancement. So this one is just short of 1 centimeter. So this is an LR4. There's a few other lesions. I mean, there's lesions everywhere. You have like washout here, but none of them meet LR5 category. So the patient subsequently had a CT, and the CT shows, what do you guys think about the CT? It's a pre-transplant evaluation.
Do you have the arterial phase?
I do. I'm going to show you coronal specifically because the finding is not in the liver.
Oh.
I hope people are not chatting in because I can't see the chat box. Any thoughts? Any relevant extra liver finding that anybody sees?
Nothing in the chat.
Okay, so there's a lesion here in the terminal ileum. The patient, this was scoped and biopsied, and this came back as neuroendocrine tumor. So what do you do next? We went ahead and got a DOTATATE study. So it's, there's uptake here in the terminal ileum. There's also uptake in these nodes, and there's uptake all over the liver. So what do you think?
So these have to be meds. Do you have the diffusion for your thing? For
yeah. Yeah, I do. Yeah, maybe. The diffusion is kind of, I mean, there is, you can sort of hallucinate.
All right.
Restricted diffusion, like throughout the liver.
Right.
Right there. Like, it's hard to see, unfortunately, but there is restricted diffusion.
Is it?
Yeah, go ahead.
No, go ahead.
What?
No, go ahead.
So he found 3 articles. You can, I don't know what you think about this, Victoria, but HCCs can take DOTATATE?
Case report, yeah, sure. But I think that I honestly don't think without PATH he can't really can't tell them apart. They can enhance very similarly. I mean, my guess is based on what you're showing, that's probably going to be METs rather than primary HCCs.
Yeah, we're treating it as METs, but this was just,
So met all the criteria for LIRADS 5.
yeah.
They biopsied it as a part of the RFA, and this was a solitary neuroendocrine met, and there's no way you can tell them apart.
Oh my gosh.
Yeah, so that's a really, really good case. Really good case. Thanks, Mel. Does anybody have?
Victoria,
Yes.
actually, we had done kind of a non-published study, just experience with neuroendocrine mets, diffusion weighted images. We had done ADC values just to see if there's anything, and ADC values of neuroendocrine mets are really, really low.
Right.
So that might be one of the ways. I mean, just to for double checking in this case.
Right. So one of the reasons why I asked to look at the DWI is because, right, usually mets are going to have much more restricted diffusion than HCCs. So if we saw these things really, really brightly, and I think I showed a case like this a while ago, that really markedly restricted diffusion in a setting of things that don't meet criteria for LIRADS 5 would really start pushing you toward thinking about LRM, other malignancy. But in this case, it didn't really fit, or DWI wasn't really contributory in a way that I was hoping.
Yeah. But
hey, Nelly, can I?
Sorry, go ahead.
Can I share my screen? I just want to show you 3 case reports on this. This is Kumar here.
Yes, please. Just click on the bottom, share screen.
Yeah. All right. So can you see my screen? It says it shows up an article, a case report.
Yes.
I don't want to go through all of this, but these are 3 case reports where there were multiple liver lesions in cirrhotics, but they also had neuroendocrine tumor, and they had DOTATATE, and it was HCC that took up the radiopharmaceutical. And this case is particularly a bit like our case, there were multiple foci of uptake. So we discussed this at the tumor board, and he has a MEL score of 20, so he's not going to be able to have any treatment, whether it's stereotactic. He can't even have a biopsy with all the ascites and this coagulopathy. So we decided we'll give him somatostatin and see what the response is, and that's how we're going to proceed.
Very good.
Okay, that's. I think I can stop sharing. I'll stop sharing.
Does anybody have another case?
Victoria, since we're doing liver cases, I do have one that's come through my shop recently that I will share.
Please.
Can you see my screen? There should be 4 panels.
Yes, thank you.
So this is a guy he was seen by us a while back, a few years ago, where there were no significant findings, but stuff that was maybe worth following up. And then he was lost to follow up, so there's the gap. And then this is the most recent with the AFP, really quite high. And so this is, I don't know if I have the non-con up, but yeah, the non-con is here. And then this is the arterial phase. This is thinner sections, and then these are fatter sections. And it's hard to see, but there's some enhancing stuff within this left lobe that's kind of heterogeneous. And the whole left lobe, if you look at the venous phase, which I've got the delay here, but the venous isn't handy. That's the delay, the one I'm scrolling. And it's kind of heterogeneous over here, but it's hard to make out what's what. But what you start picking up is as you walk off the liver out this way, there's like some enhancement here, and then here, and then here.
So,
it's kind of nodular, but contiguous and nodular out that way. I'm going to bring back which you can appreciate the enhancement a little bit better on this. By the way, there's some bland thrombus. So if you put ROIs on this thrombus that's in the main part of the left, part of the right, that stays around 30 Hounsfield units and doesn't change. Whereas this shows enhancement relative to the non-con, as does this stuff here that's kind of nodular and that goes out this way and then out that way and then out this way to here. And you can sort of see that on the, it's all this, on the coronal.
So is this tumor-in-vein in the recanalized para-umbilical vein?
Yeah, so it was
Wow.
read. It was read as, you know, maybe suspect for carcinomatosis. But if you go back to the old exam, he does have an umbilical vein or para-umbilical vein complex that's running right along this path. And so because it's sort of contiguous and tubular, we tilted towards it being TIV in the para-umbilical vein complex out of an infiltrative mass that's kind of hard to see in the left lobe here. And the AFP is it's like I said, off the charts, and he's pretty decompensated. So I think there was some discussions about oncology instead of even local regional therapy. The Y90 was floated as an idea, but it's just not going to be efficacious. But I'd never seen I was thinking to call it TIV only because it didn't look like discrete metastases or anything. It looked like this nodular tubular thing that was contiguous.
Right. Cool, really cool case.
Yeah.
Yeah. Not,
All right, that was it. That's all.
as usually, cool cases are not cool for patients.
Yeah, I know.
Okay. Does anybody else want to share anything? Okay, then I'll show another case. So this is an older case before LIRADS was introduced, at least not at Montefiore. It wasn't introduced at the time. So this is a 40-year-old woman, and she had an ultrasound for, I don't remember why, but she actually has chronic Hep B. You can see a big mass, and then so it was detected on ultrasound, and she was sent for MRI. So you can see here, this is the pre, right? You can see, the mass has some internal T1 hyperintensity, which indicates that it's has blood products. There are some areas of enhancement on arterial phase that will confirm the subtraction images. And then, washout, kind of irregular things. So, and then this was the hepatobiliary phase. Okay. So does anybody have any thoughts? Yes, if we were applying LIRADS, what would you think?
Gitanjali said cholangio or mixed HCC cholangio.
So why aren't you going for LIRADS 5?
It's not homogeneously enhancing or washing out.
Oh, it doesn't have to be. So especially at this level, HCCs of this size are very uncommonly going to be homogeneous. They're going to be usually like this, very heterogeneous, necrotic. They don't have to be, but they often are. So heterogeneity is really not a part of decision, I guess, in terms of which category to assign. So, the thought process here, are you going to assign LIRADS 5, right? It's a big mass, it's about 8 centimeters, something like that. Yeah, about 9 centimeters. It's a big mass. It has arterial phase hyperenhancement. It has washout appearance. It has internal blood product, which is a ancillary feature favoring HCC specifically. So if you're trying to decide between LIRADS 5 and LIRADS M, you would probably go, you should go with LIRADS M, because that conveys less certainty. This was actually read as probable thrombosis because she was a young woman, and they, it was a big mass, and they didn't see anything in terms of metastases. So they said, given that there's nothing bad happening elsewhere, we feel like this is probably thrombosis, but really can't tell for sure if it's something bad.
Sorry, Victoria, did you say the patient had like diffuse liver disease?
So the patient at the time of interpretation, I don't think this was known. The patient is from Africa and has chronic Hep B. But I don't think that was known.
Oh, I see.
I don't remember. I can't tell if it was known at the time of study interpretation. But
the unaffected liver doesn't show for sure cirrhotic features, right?
Right. No. The liver wasn't cirrhotic, but remember, in patients who are carriers, who are chronic hepatitis B carriers, don't have to have cirrhosis.
Right.
Hepatitis B is a tumorigenic virus. So, if this patient comes in now, again, this is before LIRADS was widely used. Case like this that comes in now, and that the patient has chronic hepatitis B,
right,
means that LIRADS is applicable. So then the appropriate category here is either LIRADS 5 or LIRADS M. Again, I would call it LIRADS 5. I showed it to Claude. He agreed. But the key point here is that it was very much misinterpreted as thrombosis because the patient was young, 40 years old, and it's true that in a young woman who wouldn't necessarily expect the badness to happen. And they the reason why the report said, we think it's thrombosis meningioma, again, because it's a large tumor, and they didn't say anything, they didn't say lymphadenopathy, they didn't say anything other signs of malignancy, which again is probably not the right approach. Because even if you don't know that the patient has risk for HCC, this is probably too ugly, aggressive looking to just dismiss as potentially benign lesion. Another interesting part of this case, so a couple more interesting parts of this case is that if you pay attention here, you actually can see that there is Tumor-in-vein. So you can see this little piece of tumor extending into the adjacent vein, which was not detected at the time of study review. So so then truly the appropriate category here is TIV, if you pay attention to this. So thankfully the patient had a biopsy, and this was actually a combined tumor. This is combined HCC cholangio, an interesting thing to remember that there's an interesting paper in radiology, I think 6 months ago, so which showed that tumors, combined tumors, combined HCC cholangios, the ones that look clearly have LRM features, so they have target appearance, they have things that truly make them LRM, they tend to behave biologically like cholangios in terms of having poor survival. But combined tumors that meet criteria for LIRADS 5, meaning they really don't have the targeted appearance, and they really fit more into LIRADS 5 category, they tend to behave more like LIRADS 5. So they have better survival, and the survival curve really matches that of typical HCCs. So it was the first paper that showed that imaging features are actually better at predicting the outcome for the patient than the actual histopathology of the tumor. So that was an interesting case on multiple levels.
Victoria, this is Kumar. I have a question. If you had a LR5 and there was a tumor right next to it in a vein, which you thought was malignant, what would you classify it as, LR5 or LR-TIV?
So if they're part of the same process, it's TIV. And then if TIV is associated with parenchymal mass, which is LIRADS 5, you would report it as TIV definitely due to HCC. And then if it was a parenchymal mass that the clear LRM, has targetable features and stuff, you would call it TIV, maybe due to non-HCC malignancy. And then if it's an infiltrative mass with, similar to what Steve showed, infiltrative mass with the TIV, we report it as TIV, definitely due to HCC. And in any other scenario, you would say causes unknown. But those are like nuances that you can find in LIRADS core. But if you didn't want to bother, you can just say TIV and that's it.
Okay. And what if the tumor thrombus was within the LR5 mass? It'll still be TIV, or does the tumor thrombus have to extend outside the tumor to be called TIV?
How would you have a TIV within the mass?
Well, I actually have a case where the tumor actually grows around a vein and it thromboses that vein. So it's not like, so all the tumor is within what is within the region of the mass. It doesn't go out of the mass. So that'll still be TIV, you would think?
I think so, but can you share the case? I'm very curious to see it.
I'll have to dig it up. I'll do it next time if that's possible.
But I would love to see the case, but in general, if there's a TIV, it's a TIV. Because remember the way that the algorithm goes, you go from top to the bottom. You start with, LRNC, and then the next node in the decision tree is TIV. So once you hit TIV,
Yes.
you don't
right,
go back.
Right. Okay, yeah. Yeah. Okay, I'll try and see if I can find that bit while somebody else is showing things.
And Victoria, on that case, I'd like to share something. This is Gitanjali. Sorry.
Please.
Can we get the images again?
Oh, okay.
So the reason I said cholangio, like a cholangio or a mixed HCC cholangio, is because you said there's history of Hep B. So obviously you're thinking of these tumors. And in my experience, what I've seen is like a cirrhotic liver doesn't get such a big lesion as HCC. If you have a big lesion in a cirrhotic liver, I mean, it has to do with, it has a component of cholangio in it. I don't know if I'm correct or not.
You must have a much better screening program. I can pull up many large HCCs.
But usually those are infiltrative.
No. I can bring you many cases, many more cases than this. It all depends on patients who get screened aggressively and undergo correct screening protocols should not get to this size. You're right, but we are in the inner city in the Bronx. Our patients don't necessarily come in with the greatest healthcare follow-up. We see large HCCs quite a bit.
Okay, in our experience, whenever we have almost a well-circumscribed big HCC, it's almost always a well-differentiated HCC, and again, those are seen from degeneration of pre-existing adenomas. And in a cirrhotic liver, I mean, I've never seen it, though my experience is very limited, but never seen such big lesions.
I can fill an entire hour of these cases if you want. We can
would love to see some cases, yeah.
No. I don't. The size is really not a deterrent. Yeah, they can be quite big.
Hey Victoria, can you show the subtraction image of subtraction for the arterial? Because you said there's arterial enhancement, if I heard you right.
Correct.
But there's already pre-T1 hyperintensity, so.
So that right. So the here we go. You can see these areas begin to enhance.
I like the subtractions for that.
Right. So right. No. You need in cases like this you would need to look at the subtractions for sure. Because you don't want to misinterpret T1 hyperintensity as enhancement, but there's certainly is enhancement. And then next week I'll bring up several big HCCs, so you don't know, so you don't think that I'm lying to you guys. But yeah.
I have one more case, if we have time.
Can I just show you my screen just to show you the two TIV cases I wanted to show Victoria?
Please.
1 second.
Kelly, is that okay?
Totally, totally.
Okay. So can you see my screen now?
Yes.
Let me put this up here. So I got two cases, and I want Victoria, how you classify these two cases. So there is this one at the top, which is a big mass that was called LR5, and this is tumor. There's this thrombus, which looks like tumor thrombus extending into it. Would you call this LR-TIV definitely due to HCC?
Yes.
Although
I would love to see the portal venous phase, but yes.
Okay, yeah, okay, yeah, I know, I don't have all the images right now, but then this other one where there's this tumor, which was also HCC, but then there's this thrombus far away from it. Though if this was LR5, would you call it LR-TIV definitely due to HCC? And if this was LR4, what would you call it?
If it's LR4, if I recall correctly, it still goes, so it goes probably due to HCC. But you would have to, scroll and make sure that it's one process, probably. Otherwise, you would report TIV as a separate lesion from the LIRADS 4. But you would say under that. Otherwise, you would say TIV probably due to HCC.
Okay. All right. So, so if it was a LR5, it's definitely due to HCC.
Yeah.
If it's a targetoid mass, you say it's due to a non-HCC malignancy, and if it's not an LR5 or targetoid, you would say probably due to HCC. Is that what you think?
Yeah, right. So just like you have there the screenshot from the core, you say maybe due to non-HCC malignancy because if you have a targetoid mass with TIV, it's still more likely to be HCC than non-HCC, but because just because of the fact that HCCs are more commonly invading the vascular system than cholangiomas, but it's not 100%. So
okay. All right. Yeah, I was a bit confused about this, but thanks for clarifying that.
So you have a nice talk there, Kumar.
Well, I don't know everything on the slide, but I've just learned one of the slides.
So this was it was actually an MSK MRI, and this was this case from our fellow Teresa Diaz. Teresa, are you on? If you are.
Yes, I am on.
So
don't
you can
have
go
the
ahead and
screenshot.
discuss.
Okay. So what are people seeing other than the hip?
There's all kinds of bubbly stuff around the rectum.
Yes, that is correct. Does anyone have any ideas of what this might be?
Colitis cystica profunda.
Colitis cystica profunda. That is a very good idea. Anything else?
could it be some sort of iatrogenic something?
Yes, that is correct. So what this is called is, or this is from, are Celesta injections. Celesta is a bulking agent that's injected submucosally for fecal incontinence. We don't see a lot of these. I was talking to a GI friend. Apparently, insurance doesn't cover these, and some of the other things that they do, I think the stimulators and stuff work just as well. So you don't really see much of this.
That's a new one.
I've seen Celeste, but I've never seen them injected this high. I've seen them injected like around the
Perianal.
perianal region, but I've never seen them in the rectum. That's very. Do you know if this is intentional or just they didn't do it the correct way?
It was, regards to how high it's placed, I'm not sure.
Very good case. Does anybody else? We have a few more minutes for another case, perhaps. Okay. Then thank you, everybody who brought cases. Thank you for a wonderful discussion. And we'll see you next week at the same time, at the same place.
Good stuff. See you next time. Thanks.
Thanks
Thanks,
everyone.
Victoria.
Thanks a lot. Thanks. Bye.